let me start by asking you what your practice patterns are for germline testing in the adjuvant or the primary setting to identify candidates for PARP inhibition.
So, the history of who got tested has really evolved over the last 30 years or so. And it began as a very selective kind of testing process. We picked families that had multiple cases of breast or ovarian cancer or very young people. And we thought that that was sufficient to identify most mutation carriers. And what's happened over the years is it's become clear that it's not. About half of the people with mutations aren't found until they themselves present with a disease that leads them to be tested, like triple negative disease or ovarian cancer. And so there's been a real movement to expand the population who's been tested. And recently, a number of professional organizations, it was started by the American Society of Breast Surgery, thought that everybody should be tested, meaning everybody, whereas ASCO and SSO were a little bit more restrictive in that they suggested that we at least offer testing to everybody who's under 60 to 65. NCCN has felt that, certainly everybody under 50, but not unreasonable to test. You can certainly offer it to people who are older than that. I think all these kind of guidelines are just basically trying to identify populations in which the testing exceeds some arbitrary threshold. But if you have somebody who is a candidate for a targeted therapy like a PARP inhibitor, it doesn't really make that much sense to restrict the testing. And so, if you have somebody in the early stage setting, for instance, who has high-risk disease, and I imagine we'll talk about that in a bit, then they could be a candidate, for instance, for a PARP inhibitor, and they should be tested. It's not that difficult anymore. And although we're going to talk mainly about early stage disease, if you talk about late stage disease or metastatic disease, anybody who might be a candidate for a PARP inhibitor in the metastatic setting should be tested, and that basically means everybody. So we've gotten much more expansive.
Yeah, it's interesting. I mean, I think, as you point out, because of the availability of a therapeutic now, in my own practice, I've really liberalized who I'm testing, and I think that sort of mirrors the evolution of the guidelines. You having led the field in terms of genetics, I'm curious, your current clinical practice in the primary setting, have you sort of moved towards testing everybody? Are you sticking with the high-risk population, younger population? Are you adhering strictly to the Olympia criteria? What's your approach in the primary setting?
Well, I mean, certainly, testing is for reasons beyond just therapy selection. And so I have tended to be more and more permissive, I guess is the word, about who I test as time goes on. I think the difference becomes how strongly I encourage people, right? So certainly, anybody who's premenopausal, hormone receptor positive, or triple negative, I encourage them strongly to consider it, and actually whether or not they have a family history. And then once they get into kind of the late 50s, early 60s, if they don't have a family history, I'm perhaps less encouraging unless there is a therapeutic reason for it. So I do think it becomes a question of how hard do I push.
That makes sense. And, I think it's interesting because, again, in my practice, I find that a lot of it is also patient-driven, right?
Mm-hmm.
They're coming to us asking us for testing.